Next, we have Dr. Treffs presenting on COVID-19 and cardiology. And Dr. Treffs is from South Dakota, earned his medical degree from University of South Dakota, and then did his residency and fellowship at University of Minnesota. And thanks for joining us, Dr. Treffs.
Yeah, thank you. It's great to be here and great to touch base with you all virtually and talk a little bit about SARS and COVID-19. So as you know, this is something that's changing constantly in the data.
Pediatric hypertension, summary of the AAP guidelines by Dr. Majed. And Dr. Majed specializes in outpatient care for common and rare kidney disorders, high blood pressure in pediatric patients. And she also does inpatient consultation for kidney conditions, dialysis, and follow-up care for transplant recipients. She earned her medical degree from Beirut Arab University in Lebanon, completed her internship and residency at Newark, Beth Israel, and her fellowship at Columbia. And she's board certified in pediatrics and nephrology. Thank you so much for joining us and for teaching us today.
Yeah, good afternoon, everybody. It's my pleasure. So today my talk is going to be really more of a summary of the pediatric hypertension guideline that came up in 2017. This was the first time the AAP sponsored the pediatric hypertension guidelines at that time. So I have no disclosures. My objectives for this talk really is for the primary providers to be able to identify elevated blood pressures in children and to establish the diagnosis of hypertension. How to initiate their workup and what should they do in terms of workup and follow-up plan of children with hypertension, and how to efficiently utilize the AAP guidelines, which is like a 75-page guideline in your daily practice. So what's the definition of pediatric hypertension? And again, so we all know in children, that's the tricky part. Everything goes by weight, by age. So the same as high blood pressure. So it's even varies in respect to gender as well, age and height. And there has been, if you want to talk in general, how childhood hypertension been defined from back to the 1970s. Childhood hypertension have been approached based on normative distribution of blood pressure in healthy children. It's different than how we define hypertension in adults, because adult definitions are based on outcome measures and cardiovascular specifically outcome measures. We do not have this data as of yet in children. And definition of pediatric hypertension from the 1970 until the updated AAP guidelines in 2017, the definition is based on normative distribution. And this is the overall definition based on this data. It goes back to the National Health and Nutritional Examination Survey, where normal blood pressure is defined as below 90th percentile for age, height, and sex. Where elevated blood pressure, so when your blood pressure is between the 90th and 95th percentile, it's defined as elevated blood pressure compared to older guidelines before the 2017, where that was referred to as pre-hypertension. Stage 1 hypertension is when the blood pressure is between the 95th to the 95th plus 12 millimeter mercury, so percentile ranges. Stage 2 hypertension is when the blood pressure is above the 99th percentile, if you want to say it this way, which is 95th plus 12 millimeter or equal or above 140 over 90 for adolescents. So that's the adolescent definition also that was updated with the 2017 guidelines, and that aligned with the AHA guidelines for adults. So those children 13 and above are defined based on adult guidelines. So 120 over 80 is normal, 120 to 129 over 80 is elevated blood pressure, stage 1 is 130 to 139 over 80 to 89, and stage 2 is above or equal to 140 over 90. And for you to define, to say your patient, so to put the diagnosis in the chart as hypertension, you should have had 3 documented elevated blood pressures above the 95th percentile for age on 3 separate occasions. Otherwise, I mean, if you have had it one time in the clinic, I mean, you can't put your diagnosis, for example, elevated blood pressure without the diagnosis of hypertension. There's many diagnostic codes that you can't put there before you can label the child as pediatric child with hypertension, which requires your 3 elevated office visits on 3 separate occasions or more. And this is, again, in red I put there the level of evidence that the AAP put in the guidelines based on data available. And this is a stage 3C, which is a moderate evidence. So this is the table that we all should be familiar with, yes, at the primary setting, and that's available in your pediatric AAP guidelines. This table essentially puts for you in the column, you're gonna find the age, the height, and the percentile blood pressures, and on your y-axis or the horizontally, you're gonna find there your percentile height, and then you can pick up the blood pressure based on that. And if you look here, these, you know, height they put even in your inch versus centimeter and the percentile height. So whatever you have data there, whether the percentile height, your real height in centimeter or inches, you can pull up that blood pressure and define your category based on this table. There's 2 separate tables, one for boys, one for girls, and this is for ages 1 to 13. And again, so what happens with children below 1 year of age? Again, these slides are available for you through the AAP website. So hopefully these tables are available for your reference in the future. For children or infants, I would say below 1 year of age, we still refer to an older guidelines, which are the second task force report in 1987. And these are the tables available. The AAP guidelines have the reference for you to pull up the whole paper. And this is the, you know, the summary table that can be easily accessible for you. Now, neonates, this is, yes? Anybody had a question? I thought, okay. So in neonates, this is a little bit tricky, but we do have some data, okay, for reference normal and high blood pressures in the neonatal population. There's this paper from the 1995 by Baroule that was the most, you know, the most paper that has been utilized for reference blood pressures. And this is again available for you. And it goes down to 24-week post-conceptual age up to 46 corrected. And the other table here that you can find an up-to-date, you can also find this reference below here in your AAP guidelines. And this table is just, you know, it's mostly made up by the group by Dr. Flynn, who's a leader in pediatric hypertension. Came up in 2012, and it's just summarized several papers that looked into normative blood pressure data in newborns, and they put it up in a table format that's easy to look at. So I would definitely recommend this table for references for especially NICUs and nurseries to have it handy. Now, why we are talking about pediatric hypertension, why pediatric hypertension has been a subject that's been coming more and more into the field of discussion and concern in pediatric population. We have had more and more data, that's number one, more and more evidence that childhood hypertension can increase the risk of vascular aging in the youth, and that high blood pressure in childhood would certainly increase the risk of adult onset hypertension and cardiovascular disease. We have, you know, we have some data there that, you know, there's a wide range of the prevalence of pediatric hypertension among children, and it's around 3.5%, okay? So that's a good percent for children to have hypertension. And there's another 10 to 11% who have the elevated blood pressure range. So this is up to 15% of your maybe clinic patients that you are seeing that will have some sort of abnormality in their blood pressure, and they should be attended to. And what we know after the 2017 AAP guidelines, there's very important aspect of that we are going to see more pediatric hypertension. There's many reasons for this. Some data there, some prevalence, some incidence studies, and there's also another thing that the guideline have made it different is the tables. So the reference tables, the normative data that we're using to look after high blood pressure for children have been modified for the 2017 guidelines, where they eliminated from these normative data children who were overweight and obese. So the normative blood pressure data that you have based on the 2017 guidelines are only for normal weight children. So if you want to think of it this way, you are going to diagnose more hypertension because yes, there's evidence that the overweight and the obese children have higher blood pressure at baseline, even if they do not fit in the category of hypertension. So this is another thing that the AAP, and the committee really raised that the flag that we're going to be seeing more hypertension after these guidelines in children. And again, we all know in adults, high blood pressure is a very, very common disease. 1 in 3 adults in the USA have hypertension. And the key contributors to cardiovascular health and hypertension in adults include their BMI, their level of physical activity, and their diet. And if you want to talk about that in our children and our population, we can talk, okay, we know that now there's enough data and evidence that hypertension rates are higher in children with obesity. But we also know that almost half of our teenagers have elevated BMI. And we know that less than half of school-age children meet the goal for ideal physical activity level. And more than 80% of our youth eat a poor diet, and only 10% may eat adequate fruits and vegetables. So based on this, all this data, we know that we're going to be seeing more and more pediatric hypertension. And I've been talking about obesity, BMI, physical activity, but as a nephrologist, we have a good chunk of our pediatric hypertension population where the hypertension disease is attributed to chronic kidney disease, and that's up to 20% of our patient population. I would say their hypertension is attributed to chronic kidney disease. So going into now, you have that patient coming into your clinic. How do you obtain blood pressures, methods of blood pressure measurement? We know that the standard, everybody recommend auscultatory measurements using appropriate cuff size. This is, the gold standard to obtaining an accurate blood pressure. Yes, we can use oscillometric devices, and the guidelines definitely recommended using them because, again, after ease of use, their screening, overall status. But if your oscillometric blood pressure measurement on initial triage for your patient is elevated, you should be getting a confirmatory measurement by auscultation. So this is a strong recommendation. And yes, we all use it, even as a pediatric nephrologist, when my patient gets triaged and they get, oscillometric blood pressure measured, and my nurse was going to take also a manual, but I also repeat that manual again, because that first blood pressure as your patient walks into the clinic, most of the time is going to be higher than when you recheck it when your patient calms down and throughout the visit. Ambulatory blood pressure monitoring. So that's one method where you can check blood pressure, but we understand ambulatory blood pressure monitoring, you're using more of a sophisticated equipment. It's not as widely available, especially for children. But with the 2017 AAP guidelines, they definitely weighed really higher, emphasis on the use of ABPM for diagnosing and managing pediatric hypertension. We are not at a stage yet for widely used ABPM. So like just, you order it like this as a routine test. So the guidelines recommended the use of ABPM for every child who has had more than 3 elevated blood pressures and on 3 separate uncounted, or had evidence of high blood pressures over like a year period, to do an ABPM to confirm hypertension. But also more specifically, ABPM is definitely, and that's where I do it definitely as a pediatric nephrologist, we're in high-risk population. And these include chronic kidney disease patients with coarctation of the aorta, even after complete repair. There's very strong evidence with patients with coarc, even after complete repair for a long-term risk for hypertension and what we call specifically masked hypertension. So your office blood pressures are very assuring and normal, but these patients will have evidence of masked hypertension when we do an ABPM. So all these kids who have had coart out there for you, just refer and we will do their ABPM, because that's a very strong recommendation, and up to 70% of these patients would turn out to have a masked hypertension. Why called hypertension, of course? So you have these teenagers, young girls, young boys who are even, telling you I'm anxious, and they may be sweaty a little bit, they may be a little bit tachycardic in your office. So what called hypertension definitely is a very strong, recommendation for doing ABPM. In those children who I do not have a significant risk factor for hypertension in the youth, and I will always consider ABPM before diagnosing hypertension to rule out white coat hypertension in this population. Now, your other way of obtaining blood pressures is your home measurements. And this is a very controversial thing. We do use it as pediatric nephrologists, and also the guideline reiterated that you can use it to monitor established hypertension and to not use it to diagnose hypertension. Because again, there's many details that is around this and may make, may make your workup even tougher and harder to rely on. So within the guidelines, so this is all in the guidelines, is just really summarizing. As we said, your initial blood pressure management can be oscillometric. It has to be on a calibrated machine that has been validated for the use in the pediatric population. And sometimes, you need good luck to find that calibrated machine. There's not a lot of data there. Yes, for office use, hospital use, there's maybe more data than home use blood pressure devices for pediatric hypertension. So you will find that, and this is your resource here. It's the ablEducational.org, and that's also available at the AAP and the AAP recommendations for you to be able to refer to find devices for your clinic and make sure they are validated for clinical use in pediatric population. Now, how do you measure blood pressure in children? Again, children of different sizes, of different age, of different arm circumferences, of different weight. Having the accurate cuff is extremely important to obtain an accurate blood pressure. Larger cuff is going to underestimate, but more importantly, much more importantly, is a smaller cuff is going to overestimate your blood pressure. So if you are in between, if this looks a small cuff, always round up, increase your cuff size better than going down. And if you are, hesitant on what cuff size you want to use, you can measure the mid-arm circumference. And this is the way it's showing you from oleclunion to up here to the scapula. So it's just having that midpoint and then measuring the circumference around that midpoint. And this is the cuff for you to get more familiar with. Your cuff bladder, which is the inflatable part of the cuff, should be 80 to 100% of your arm circumference, mid-arm circumference, and 40% of that width of the cuff should be 40% of the width of the cuff should be covering the mid-arm circumference as well. So this is overall. If you got stuck, what size I should be using on this specific child. And again, there is a very nice video to illustrate what I talked about in terms of how to obtain an accurate blood pressure, the details about it. That's also more detailed in the AAP guidelines, and this is a video that also the guidelines refer you to by the AAP that you can watch as well. How frequent you measure blood pressures in children. So the guideline recommended annual blood pressure measurement in children 3 years or older, and this is a moderate recommendation. But then there's certain, special population of patients where you have to monitor their blood pressures more often. So for those children above 3 years of age who have certain conditions, obesity, kidney disease, history of coagulation, as we have said already, diabetes. They are on medications that raise your blood pressures. Yes, stimulants, steroids, other medications. So make sure these patients get their blood pressure checked with every healthcare encounter. Now, in children below 3 years of age, we all know how cumbersome it gets to check a blood pressure in an infant. But yes, there are infants who are at higher risk of early onset hypertension, and this is a category of patients. There is a recommendation to check up their blood pressure with every healthcare encounter. And these include infants with history of prematurity, neonatal complications, need for catheters, mechanical ventilation, lengthening courses. Children, of course, with congenital heart disease, children who have had recurrent history of urinary tract infections with renal or urologic abnormalities, history of solid organ transplant and malignancies, and of course, children who are on chronic medications known to increase blood pressure, and those children with increased intracranial pressure. So this is the category of infants you have to check their blood pressure with their encounters before their 3-year of age. How do you follow up on elevated blood pressure in your office? So you got that high blood pressure that was, above your 90th or 95th percentile for age. That first visit, always lifestyle interventions and modifications have to be recommended, whether in terms of physical activity and diet. And we talk about that in detail a little bit. And then if that blood pressure is a 90th to 95th percentile, you just do these lifestyle interventions, and you repeat, you have a follow-up visit with that patient at 6 months for repeat blood pressure after implementing, hopefully, these lifestyle interventions. Now, if your blood pressure is a stage 1 hypertension, which is above 95th percentile to the below 95th plus 12, so bring that patient back in 1 to 2 weeks and recheck blood pressure. The blood pressure is still at stage 1 hypertension. You should be obtaining an upper and lower extremity blood pressures, and that's to rule out any gradient or any aortic coarctation or even mid-abdominal aortic stenosis of the heart. And you have to recheck, bring them back to recheck in around 3 months. And if that blood pressure continues to be in the stage 1 hypertension after 3 visits, okay, ABPM, again, as I said, the guidelines stress a lot on the utilization of ABPM, but I would ask you leave that to the pediatric nephrologist to order. But you definitely can start initiating your simple diagnostic evaluations and refer the patient to us as needed. And we'll talk more what would be your diagnostic evaluation that should be done after these confirmed high blood pressures in the office setting. Now, if your blood pressure is at the stage 2 hypertension, so you obtain that first blood pressure and it's above the 95th plus 12 millimeter mercury, you have to obtain an upper and lower extremity blood pressure from that first visit and repeat or refer within 1 week. So that has to be followed closer. Now, if that blood pressure is at stage 2, but your patient is also symptomatic, that's an emergency. So that's more of a urgent referral, whether that blood pressure is above 30 millimeter, above the 95th percentile, or above 180 systolic for adolescents, that's an ED referral. So this is, your usual follow-up, and I would tell you, really, this is very, very well, as stated in the guidelines. Very easy format. They have it in a table form that I'm gonna share with you later. Very easy to navigate through. What is the etiology of hypertension in children? Okay, so up to 75% of adolescents will have primary hypertension. As we said, we talked about lifestyle, we talked about, diet, obesity, BMI. Yes, we know our pediatric population are at higher risk for primary hypertension. So primary is the most common that we're gonna see even as pediatric nephrologists in our setting. What's the common causes of secondary hypertension? Of course, it's gonna be primarily renal. So renal parenchymal structural diseases, much less commonly renal vascular disease, and much less common is endocrine etiologies like your hyperthyroidism, your Cushing, your secondary adrenal hyperplasia. So these comes much lower on your risk, where these are much rarer diagnoses. Now, how for you as a primary provider, you're gonna be evaluating that patient with elevated blood pressure? What's your thoughts on what's causing the high blood pressure? Is it a really primary hypertension or secondary hypertension? And that's extremely important because it's gonna direct your further workup and referral. Overall, with the guidelines and all the evidence available, yes, we have lowered a lot the age of children presenting and having us suspecting primary hypertension. So if your age is at or above 6 years of age, but also that's plus on top of that, this 6-year-old or 8-year-old is obese, has no symptoms of hypertension, and there's a very strong family history of hypertension, this is more likely this is a primary hypertension. Now, if you have younger children, less than 6 years of age, or even older, and they have no family history, they're very fit, they have a healthy lifestyle, these are all, red flags for you to think of more secondary forms of hypertension. And yes, diastolic hypertension is definitely a factor that you have to look at with secondary forms, specifically renal renin-mediated hypertension, where the diastolic blood pressures are more remarkably elevated. Of course, we talk about history all the time and physical exam. And again, for you to differentiate between primary and secondary hypertension, that's your go-to. This is 80 to 90% of your evaluation based on history, physical exam. That's gonna get you to think, is this really primary or is this secondary hypertension? Very important points in your history. What's your perinatal? Okay, history of prematurity, history of, as I said, umbilical catheters, perinatal hypoxia. What's your lifestyle? Okay, what's the patient's nutrition like? What's the physical activity like? Are they on any medications that can increase high blood pressures? What's their, do they have history of recurrent urinary tract infections? Do they have history of kidney disease or urologic abnormalities? And do they have a family history of hypertension? Just knowing all of these points can really, really shift you with the differential, whether you're dealing with a primary or a secondary form of hypertension. And your physical exam, I don't want to go into so much details, but of course, your overall appearance, you have an obesity distribution, more truncal, you have a failure to thrive child with hypertension. Oh, this is kidney, this is chronic kidney disease. You have a tachycardic patient with high blood pressure. This is not a combination when your hypertension is renal or primary, because usually with significant hypertension, you get reflex bradycardia. So if you're tachycardic and hypertension at the same, hypertensive at the same time, you want to think more of course, anxiety, white coat. But then if you want to think of the organic stuff, you want to think of hyperthyroidism, you want to think of pheochromocytomas, these rare entities and Cushing. So this is, part of the overall physical exam evaluation. Your faces, outfit faces, your Williams syndromes, where you are high risk for cardiac and renal artery stenosis as well. You have border, you have wet neck, you think of your Turner girls, any other also skin, always ask for, birthmarks, cafe ole spots, where you're gonna talk about neurofibromatosis and associated syndromes. You have acanthosis nigricans in an obese child. So this is all details of your physical exam that can direct you really to where you are standing in terms of what you're thinking. Is it this primary or secondary hypertension? And that's when it comes to the workup, yes? So if you have a child above 6-year-old who does not really have a family history of positive for high blood pressures, they are overweight or obese. So you do not need extensive evaluation for secondary hypertension in these children. And especially, as we said, if you have all these risk factors that we delineated. And usually that initial workup, all children should be getting a basic metabolic panel, a urinalysis, and a lipid profile. Now in obese children, of course, comes in your HbA1c, your fasting lipids, and your liver enzymes. And based on your history, then you have to go through the other, more extensive, more expensive evaluation and workup as needed to look into your secondary etiologies of high blood pressures. When it comes to imaging, okay, renal ultrasound. So the guidelines specifically indicated that children who are above 6 years of age, who have a very, clear family history of high blood pressure, they're obese, they may not need that, especially if you have a normal kidney function. Now, children below 6 years of age, those who have abnormal urinalysis or renal function, this is when you want to obtain your renal ultrasound. I still tend to get one. So even in the older children, I want to look at their renal health. I want to see their kidney size. I want to see echogenicity. Who knows? Do they have a de novo, a DPKD mutation, whatever? I always tend to do the ultrasounds, again, at one point in my evaluation, especially if I'm going to start these children on pharmacologic therapy, just to confirm really nice, good renal anatomy, because that can change a little bit of your long-term follow-up. Now, duplex, okay, so I get a lot of referrals of children who have high blood pressure who already had a renal Doppler. Now, the guidelines and all the evidence available, renal Dopplers are not highly sensitive for diagnosing renal artery stenosis. But this is a better test to do, and it has a better sensitivity in the non-obese and in those older, above 8 years of age. Those children who are the children who I would obtain a renal Doppler, especially, again, there's another aspect of this. You need an experienced center. So you know that you do that, you know, this is a program that we do it more often than usual or not, or are we good at doing it or not? So Dopplers are a little bit controversial in their diagnostic ability. They're not as sensitive, so they may put you in a hard spot. Now, renal, coming to more detailed imaging, CTA, MRA, can be performed as non-invasive imaging studies, but both of them and neither will substitute angiography. So always as a specialist, we have to weigh that, you know, benefit and risks of exposing this patient already to radiation, contrast, sedation if needed in younger children, whether I do the CT-MRA, which still has that little false negative, you know, probability, versus I just go ahead for angiography. This is, I mean, this is more something that I don't want you to do as primary providers, because again, these are more invasive, more testing that can a little bit tricky of what you're gonna get in this specific patient who you are suspecting renovascular hypertension. EKGs, okay, so we get a lot of children who have had an EKG done. EKGs are not recommended for screening for left ventricular hypertrophy. They have low sensitivity, and yes, they do have high specificity, but as we all know, for screening with lower sensitivity is not the best thing. So EKGs are not recommended for screening for LVH. Echoes, yes. So echocardiogram, it's recommended that an echocardiogram be done as a consideration of pharmacologic treatment when you have a confirmed hypertension patient. So what's your goals of treatment, okay? So you wanna make sure that your blood pressure is controlled, both the systolic and diastolic below the 90th percentile for age or below 130/80 in adolescents above 13 years of age. Treatment could, as we said, could be non-pharmacologic or pharmacologic or both, and always non-pharmacologic measures have to be applied in all our patients. Your DASH diet, yes. So dietary approach to stop hypertension diet has been scientifically proven to decrease blood pressure solely by itself. And this is by increasing more fruit and vegetable portions. So we recommend 4 to 5 servings of each every day. We recommend lowering the salt in the diet to 2 grams of less in adolescents, and usually in children we go by kilos. And we ask them to introduce more, you know, more plant-based oils and fats rather than animal-based. And we ask kids, again, we ask families to try to find ways to increase physical activity. Moderate to vigorous physical activity at least 3 to 5 days per week, and 30 to 60 minutes per session. We all know how this is hard. Changing lifestyles can be very, very hard. And we understand, and, you know, we have always this, you know, I meet the patients and I will be discussing dietary modifications. Okay, busy parents cannot have time to cook. Socioeconomic status can play a role in healthy eating and buying healthy food, unfortunately, and we all know this. Now, how you want to talk with the patient, finding ways, improving their diet, it's going to be tricky, but we all try our best to do any changes. And we do, you know, get to the discussion. And when we have that conversation, especially if you have an adolescent patient, motivational interviewing is your go-to. Yes, it has been definitely a way of improving your patient compliance and adherence to treatment. It's more of a patient-centered communication, for the provider being empathetic, non-judgmental, supportive, and asking more open-ended questions. Yes, and having more listen to the child, see what's there. Maybe have open-ended questions. Ask them, okay, what do you think? What do you feel like? What's the best way? And what do you think? What's preventing you from making more activity in your life? What's preventing you from participating in sports or having more physical activity, and find ways to improve that. Now, pharmacologic therapies, and when we talk about starting on pharmacologic treatments, we want to know that the patient who have stage 1 hypertension, sometimes you opt to just having some lifestyle modifications if your child has already have high risk factors with obesity, bad lifestyle, high salt diet. So if your non-pharmacologic interventions failed after 6 months of trial, then you start treatment. If you have already, of course, an asymptomatic hypertension, or if you have stage 2 hypertension, or if you already have an evidence of end organ damage, or you have already a secondary hypertension that you're suspecting, there, definitely that's where you want to treat these patients with pharmacologic agents. The AAP recommended 3 first-line agents, 1 of 3. So, preferences depends on the risk factors, and I usually opt to one over the other based on the patient populations I see. Angiotensin converting enzyme inhibitors or angiotensin receptor blockers are one of these 3 agents recommended. Long-acting calcium channel blockers and thiazide diuretics. Beta blockers, on the other hand, centrally acting agents, more potassium-sparing diuretics, vasodilators. These should be reserved for children who are not responsive to 2 or more of the preferred agents above. So again, the three that should be used, and they depends on your patients. I would possibly, ACE and ARBs are extremely, extremely important in patients with already known CKD. So this is our number 1 go-to medication because of their renal-protective properties on the long term. We use ACE and ARBs a lot on CKD. CKD patients, and we screen these patients for proteinuria because evidence of proteinuria, this is a recommendation for these patients to be an ACE and ARB. Even if they do not have hypertension, we sometimes use an ACE and ARBs just for their anti-proteinuric effects. And I would probably go with thiazide diuretics. Sometimes African Americans usually are more salt sensitive. They're not as good responders to ACE and ARBs usually compared to other ethnicities. We look into, they are good actually, they do well with calcium channel blockers as well. So it differs really on what patients to choose the agent to treat these blood pressures. And after you start treatment, that's your follow-up, and that has to be closer, yes. So after you are on medications, you have to follow patients closer until you make sure that your blood pressure is at goal, below 90th percentile for age, height, and gender. And that's when you are able to space your visits and your follow-ups. Sports, so we all know, and there's studies that sports increasing physical activity improve blood pressure in children. So all children with hypertension should be advised increasing physical activity. Now, when it comes to competitive sports, that's where you want to be a little bit, careful. If you have stage 2 hypertension, or if you already, or you're concerned, or you already have evidence of target organ damage like left ventricular hypertrophy. So these are the patients you want to evaluate them before giving them a, green light to participate in competitive sports. So an echocardiogram of these patients, evaluating cardiac function, left ventricular hypertrophy, and controlling blood pressures below stage 2 hypertension level is extremely important before you can let them participate in competitive sports. Finally, how to utilize these guidelines. It's an extensive guideline, 74 pages. It has 3 key action statements with level of evidence for each of them. There's 27 additional consensus opinion recommendations. And if you want to look at it, it's very simple. There are a few things that you can quickly navigate through when you're busy. Tables, So there's table 1, that's your key action statements. These are the evidence-based recommendations that you can review in probably less than 5 minutes. Your table 2 is your consensus opinion. These are based on, again, on experiences and not as evidence-based as your key action statements. You can review both of them, again, in 5-10 minutes maximum. Now, when you wanna, again, when your patient come in for blood pressure measurement, and as we said, now we are having better tools to be alerted to abnormal blood pressure. Yes, so Epic, whoever uses Epic, there's many EHRs who are now modified to alert the provider to what's the blood pressure range for your child on triage. So it will alert you, is it above 95th percentile, above 90th percentile for age, height, and gender. This is very, very good. And you can utilize that in your very busy day, because looking at these extensive tables can take you a time in your busy practice, and there's 5 pages. But also the AAP understand that if you do not have this, EHR smart thing that to get to know where's your blood pressure range, there's this simple table. Okay, this is just an overall screening table that puts in the 5th percentile high blood pressures for each age. So you can use it as a screening blood pressure quick. 1-year-old, okay, that's 98/52. 5-year-old is 103/63. And then if your blood pressure, your child's blood pressure is above that, then you go to the detailed tables to see where they sit really at. Because 103/63, that's for 5th percentile high. And if your child is at the 90th percentile high, that can be up to 5 millimeter mercury difference. So just be careful. This is just a screening BP table. You can find it handy, put it on for the nurses. If you don't, again, cannot really, the nurses can alert you, okay, this patient needs to have their blood pressure rechecked. So it can be in the nurse's triage room, quick access to them so they can alert the provider to recheck blood pressure. This is when I talked about follow-up. This is, again, another very, very, very simple table the AAP guidelines had for you there, how to follow up on elevated blood pressures in your office setting. From first measurement, second measurement, third measurement, based on your BP category, stage 1, normal, stage 2, hypertension. Very easy reference table, just you can know from here what you should do next. And finally, this is the overall workup that is, as we mentioned again, it's in table format. And again, it's easy to look at. If somebody had to review again, what should I get as a workup in my patient with high blood pressures? This is easy. This is in a table form. Again, you don't need to dig into the guidelines to find what you need to get for your patient for the workup. Resources, so there's family patient resources on the AAP website, there's provider resources, there's, if you want to say, there's an EQUIP, QI project for hypertension for primary providers and for nephrologists. Unfortunately, I think it's gonna expire around April, so I'm not sure if you need a more of a busier practice, seeing higher patient numbers to be able to be done with this project before it expires. But overall, there's a lot of resources there for providers that can refer to for that purpose. Thank you, everyone.
Thank you so much.
Okay.
We had one question in the chat box, and I think, well, we had a couple in the chat box. If you're able to check in there afterward, we can have you respond in the chat box. There's just one that I think will be a quick answer. You had mentioned doing blood pressures on premature babies. What gestational age of prematurity is it recommended that is done for?
So as early as their birth, yes. So in the NICU, they're gonna be in the NICU after birth, yes. But when they are discharged, that's what they meant.
I'm sorry, I meant like they're born before 34 weeks, or?
Oh, you mean? Oh, sorry. So for history of prematurity. So there's no cut point for the prematurity age. But yes, if you have a child who has history of 30 weeks prematurity, but they spend in the NICU several weeks and they were on mechanical ventilation, had lines in, this is a higher risk patient. Now, if you have a 24, 26 weeker, you already know that they had an extensive course. So this is a higher risk patient. Now, above usually 28, 29, these babies relatively do better in their NICU. And also when we talk about the specific risk for renal maturity, so renal development, that's another risk factor for hypertension in these infants, even without having an aggressive NICU course, because your renal development in utero starts as early as 8 weeks gestation and continue until 35 to 36 weeks gestation. So any child who is born before 36 weeks, they have not completed renal development. There's glomerular development. So there's evidence that you can continue postnatal renal development for 30 days after birth. But this depends again on your NICU course. So if it's very aggressive, these definitely patient had AKI already, was sick on medications and nephrotoxins. There's already a risk that they have not had that chance of that 30 day as well. So that's why, I mean, overall, any premature child, not only prematurity, IUGR, so even if you have a full-term child who was born with intrauterine growth restriction, these are children who need their blood pressure checked more often because IUGR by itself is associated with lower nephron mass as well. So this is, again, your perinatal history is extremely important, and finding these. And again, now there's adult studies that have looked into this, because now we know there's an extensive population of who are already adults, came out from more severe prematurity and extreme prematurity. And there are some adult nephrologists now understand, and they ask actually about about this history if they have not a reasoning why their young adult with normal body weight have high blood pressure. So this can be a risk factor that extends into adulthood as well.
Thank you so much.
You're welcome.
The presentation and the review of the recommendation.